Hi, my name is Shay. I'm from Western University.
And my name is James. I'm from Lincoln Memorial University, and we're going to be going over some of the most commonly used and encountered cardiovascular medications while on your rotation here with Dr. Ben-Zur. So, what are some of the positives to knowing? Well, knowledge is power. The patient's most common questions I can tell that I've heard are going to be, why am I taking this medication? What does it do? And what are some of the side effects? So, again, knowing mechanism of action, side effects, and of course, the name is going to be huge in your patient encounters.
So I'm going to go ahead and start us off with antiplatelet therapy. I'm not going to go too in depth into it. I do want to highlight that the way we talk about medications on the SOAP note as well as patients is going to be trade names of the drug. So you definitely want to be familiar with that. The ones I've seen most commonly is Brilinta, Effient, Plavix, as well as aspirin.
Our next group of medications are going to be the ACE inhibitors, aka the Prils, as we know them from board study. Unfortunately, again, a lot of these prescription names are going to be the common patient names they know them by, so it's good to just zip through them while you're looking at the chart. Just a reminder, an ACE is going to block angiotensin 1 from becoming angiotensin 2, and one of the most common side effects that I see with patients here is obviously going to be cough. This is also one of the major reasons why we switch them off the medication to another option.
So building off that, I'm going to talk about the angiotensin receptor blockers, also commonly known as Sartans. At this office, the one I've seen most commonly is Benicar and Adarbi, mechanism of action being blocking angiotensin 2. One patient might be on Adarbi for a week and they might complain of some side effects. What you might see happen is instead of continuing the Adarbi, we'll discontinue it and place them on Benicar.
The following group of medications is going to be the Aldosterone Antagonist. Just a reminder again, aldosterone being a natural hormone based in the body, which is a vasoconstrictor. This can also occur from many end organ failure issues, CHF, and again, our goal is to block any of the receptors for aldosterone, lowering the blood pressure overall.
I'm going to mention the calcium channel blockers. The ones I've seen most commonly is going to be Procardia as well as Norvasc. Indications including angina, ventricular rate control, and hypertension.
The beta blockers are going to be specific normally to beta 1, possibly beta 2 receptors, beta 1 being the most common, located on the heart, as well as systemically for renin. The most common that we see or use around this office is going to be systolic normally, as well as low pressor. As a common side fact, they are most commonly prescribed to a person who has had a recent MI, so that they are not having a tachycardic rhythm.
Next up, I'm going to go over very briefly the psychologic medications you might see. Obviously, this is a cardiovascular institute. However, you're going to run across patients that also have psychiatric issues. I think a very big point we're trying to drive home right now is that you want to know the medications before you go into the patient encounter, so you have an idea of what kind of patient they're going to be, and so you can just prepare yourself and not just be thrown out there and have no idea why a patient's acting a certain way or talking to you a certain way. So the ones I've seen most commonly is Zoloft and Prozac.
So on to the statins, aka the cholesterol stoppers. As a reminder, statins are going to stop HMG-CoA reductase, halting the cholesterol pathway. The most common that we use at the office are probably going to be all three, but most likely Crestor or Lipitor. Some of the side effects commonly that we see with patients following up who have just started a statin as well can be most commonly muscle cramps.
Next up, we have the proton pump inhibitors. I feel like I've seen all three of them: Dexilant, Prevacid, Prilosec. Patients will come in with some GI complaints, so they will be on these medications. If you see these medications, something to keep in mind is that we might be referring them to another GI or nearby hospital that can better handle these issues. Again, driving home the point that if you know the medications, you're already going to have a good idea of how to best treat them, how to refer them correctly to different doctors. So just be aware.
So warfarin, one of our big hitters for anticoagulation, aka Coumadin, it's going to block the production of vitamin K as its mechanism of action, stopping the production of clotting factors. Warfarin is known for its very narrow therapeutic index, so we tend to see patients back on a weekly basis for an INR test. INR we usually shoot for is between 2 to 3, but that can vary depending on the patient's disease and such, and also can be followed by a strict diet.
So, this isn't a comprehensive list. For us, I think what we're really trying to drive home is know the medications and know the trade names. It's always embarrassing and it's never fun when a patient knows more than you. That should never be the case. It's pretty fast-paced here, but always take the time to at least have an idea of the trade names, medications, mechanism actions, whatever it takes for you to get there, whether it's a small little spreadsheet. Just make sure you familiarize yourself, and it's going to pay off dividends in the long run.
Absolutely. And just to drive home the point, too, you will be seeing patients. You are the student doctor. They do expect you to know a lot, but we need to make sure that we are reviewing all the patient's medications each time they come in, including dosage and frequency. And honestly, a big thing that we tend to do with patients is to remind them to take them as they are prescribed. Patients tend to run into a situation where they are feeling better, noticing better blood pressures, seeing better heart rates, and they will tend to stop or even cut down dosages of a certain medication. So make sure that you, again, drive the point home of why they're on it, how much they should be taking, and when they should be taking it at each and individual visit.
All right, thank you for your time.